Support for the Journal of Clinical Oncology podcast is provided in part by AstraZeneca, dedicated to advancing options and providing hope for people living with cancer. More information at AstraZeneca-US.com.
The guest on this podcast episode has no disclosures to declare.
Hello and welcome to our 2025 ASCO annual meeting series, where we cover some of the top JCO papers published simultaneously with their abstract presentation at this year's meeting. I'm your host, Dr. Ece Kali, JCO editorial fellow, and I'm joined by JCO Associate Editor Dr. Tom Stinchcombe. In this episode, we will discuss the Journal of Clinical Oncology article and abstract presentation, Neoadjuvant Osimertinib for Resectable EGFR-Mutated non-small cell lung cancer. NeoADAURA is a randomized global phase 3 study investigating the efficacy of neoadjuvant osimertinib-containing regimens in patients with resectable EGFR-mutated stage 2 to 3B non-small cell lung cancer. 358 patients were randomized 1:1:1 to receive osimertinib plus chemotherapy, osimertinib monotherapy, or placebo plus chemotherapy in the neoadjuvant setting. The primary endpoint was major pathological response. Osimertinib plus chemotherapy and osimertinib alone demonstrated MPR rates of 26% and 25% respectively, compared to 2% in the chemotherapy plus placebo arm, with a p-value of less than 0.001. Tom, can you please explain to our listeners how you interpret this data?
Great question. I think giving a little context, obviously chemotherapy and immunotherapies preoperatively is becoming the standard of care. However, patients with EGFR-mutant lung cancer generally have not responded to immunotherapy, and many of the trials excluded patients with known EGFR mutation. There have been smaller phase 2 trials that had looked at EGFR TKIs preoperatively, but none of these were definitive. So I think that this trial is a big trial, and I think some of the strengths are that it has osimertinib alone and chemotherapy with osimertinib arms, and it's compared to the standard of chemotherapy. I think it's going to be really interesting at the meeting to see how this is discussed by the discussant and also what the reaction to its public presentation. And I think that's largely because there's an alternative paradigm now of surgical resection and adjuvant osimertinib that's available to patients. So I think this will be interesting to see what the reaction is to the induction therapy. For patients with known N2 disease, I've generally given some form of induction therapy prior to surgical resection. So I think that's the subgroup of patients that I'm most likely to employ this approach with based on the results.
So in this trial, more than 90% of the patients on the osimertinib-containing regimens underwent curative intent surgery. So this speaks to the feasibility of the approach, and the higher MPR rate with osimertinib-containing regimens is encouraging. Event-free survival data is currently mature. You have already touched upon some of the strengths of the trial, but what are the weaknesses and the strengths of this trial?
So, I think there are some weaknesses. A major pathological response was chosen as an endpoint, and there could be an argument that path-CR is more of a prognostic marker. However, the rates of path-CR are relatively low, so it would have been very hard to design a trial such as that. And then I think the trial started off as a preoperative trial, but effectively became a perioperative trial with preoperative EGFR TKI, postoperative osimertinib. And so I think it's going to be very hard to determine what the contribution of the components are. And then you've hit on another part that I think is very important when we interpret the data, that at the maturity on the event-free survival is only 15%. And most people are still on therapy. So the event-free survival, which is an important endpoint, is very immature, right?
Mm-hmm. And this trial was designed to compare the neoadjuvant approaches. Hence, the comparator arm here is neoadjuvant chemotherapy followed by surgery. So considering the ADAURA trial results with upfront surgery followed by osimertinib as adjuvant, so how do you see this trial's impact on the current clinical practice?
Well, very good question. I think one that we're still struggling with as we kind of look at this data. I think for me, stage 2 patients will most likely go to surgery and then get adjuvant osimertinib, and then maybe the N2 patients will get an osimertinib-containing regimen as an induction therapy. I think one of the questions is, does it really matter when you get to osimertinib, as long as you get it at some point? And I think that's going to be the critical interpretation of some of the data at this point.
And how do you think this trial shapes the future research for patients with resectable EGFR-mutated lung cancer?
Well, I mean, I think it shows that the chemotherapy was really modestly active with an MBR rate of 2% and no pathological responses. And then I think you're going to have to look at an osimertinib plus another targeted therapy component. I think, when I looked at the osimertinib versus the chemo osimertinib arm, I also was sort of surprised that the MPR rate and the path-CR rate were very, very similar. So I think the question is, would a double targeted therapy approach or some other approach matter? And I think it also sets a safety standard. And you touched on this in your comments, that there was not a disparity in terms of the rate of going to surgery or RO1 resections. So patients were not having progressive disease events or toxicities that prevented surgery. So I think it does give us good safety data.
Tom, thank you so much for sharing your insights on the JCO article, Neoadjuvant Osimertinib for Resectable EGFR-Mutated Non-Small Cell Lung Cancer. Join us again for the latest simultaneous publications from the 2025 ASCO annual meeting. And please take a moment to rate, review, and subscribe to all ASCO podcast shows at asco.org/podcasts. Until then, enjoy the rest of ASCO 2025.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.